Thank you for being here, and welcome to the annual IPEC Case Conference. I'm George Bottomley, Director of the PA program, and one of the people who's been involved in putting this case conference together today. So thank you so much for being here. Our students are wearing yellow ribbons. I want to explain that first. The University of New England is a yellow ribbon university, which has particular relevance to veterans. We are very open and very encouraging of veterans to work with us and become our students. So that's why our students are wearing yellow ribbons, and that's a little bit of a history behind a yellow ribbon university. Actually, this event today, I want to give you a little bit of the background in terms of what's happened since late last year and this past semester in what got us here today to be privy to this conference. A group of us met late last semester, I think, and one person I want to single out in the room is Colonel Andrew Gibson from the Army National Guard. Colonel Gibson, thank you for being here. And I want to ask, are there any other veterans in the audience? Raise your hand, stand. Thank you for your service. But last semester, as part of the institution's becoming a yellow ribbon university, a bunch of us came to the table with the concept of having today be a conference that revolved around a veteran, and that's what happened. Over the course of the last semester, we've been working with our colleagues at TOGAS, Veterans Administration Hospital in Augusta, as well as the Portland VA Clinic in downtown Portland, to help us identify the patient that our interprofessional student team has been working with this semester. So thank you very much for that. Our students this past semester have spent an incredible amount of time not only meeting with our patient, but also visiting the patient's primary care provider, going on various medical appointments with our patient, meeting with him in his home, and learning more and more about the Veterans Affairs system and the health care that it provides. We've had great dinner meetings in the past semester, and they've put on they've done an incredible amount of work to get to where we are today. I also really want to acknowledge every student on stage this semester has had a faculty member from their department as their advisor. And their names are listed on the program. I'm not going to take the time now to go through them individually, but I really want to thank my colleagues on the committee that helped put this together today. It was an incredible amount of time and energy that everybody put into this, so thank you very much. I think I'm going to stop talking now and turn it over to the students. They're going to introduce themselves and tell you all about today's presentation, and then give it to you. Thank you very much.
Good afternoon. I'm Kara Scale, and I'm a first-year PA student. Welcome to the annual Interprofessional Educational Collaborative Case Conference. This is an opportune time for this presentation to take place because many of us had the privilege of attending the Spring Symposium, which allowed for the unique opportunity for UNE programs to come together and discuss the case of Michael Goulet. Today, on stage, is a team representing 7 professional programs that was given a real, complex patient as a vector to learn what working as an interprofessional team really means. This presentation will be a reflection on this process in the form of a kind of grand rounds, as well as an intricate look into the Veteran Affairs system, a reflection upon the lessons learned, and the applicability of the Veterans Affairs system to the future UNE Health Clinic. Lesson 1, know your colleagues and their expertise, because when your knowledge and skills are exhausted, knowing your resources will make all the difference. With this in mind, I have the honor of introducing Kylie, a second-year Doctor of Osteopathic Medicine student. Osteopathic physicians are able to practice just as allopathic physicians would. However, they are noted to have a more patient-centered approach to medicine. Emphasis is put not only on treating the acute disease and illness, but also on the lifestyle modifications that are essential for maintaining wellness. For this reason, osteopathic medicine also emphasizes an interprofessional approach, an appreciation for team-based medicine, and utilization of the expertise of multiple providers. In addition, osteopathic physicians are trained in osteopathic manipulation, a specialty that requires intensive anatomy-based knowledge and mindfulness of the interconnectedness of the body and its systems. I'll now turn over the mic to Kylie.
Well, thank you guys, and thanks, Karis. So I'm now going to introduce Karis. Karis is a first-year student in the Physician's Assistant program. PAs are relatively new to the medical field, but are forging their way with bright and dedicated students like Karis. PAs go through a rigorous 2 to 3 year training program, and in the end, can practice and treat patients essentially as any doctor would. They do generally have a physician who they collaborate with or who technically supervises them, but depending on practice location, that physician could be many miles away. So PAs are very autonomous. But this collaboration with physicians, and of course with the many other professions within the medical field, demands that PAs have the skill of working on an interprofessional team. So now I'm going to pass the mic over to Sima, Lindsay, and Colleen, who are going to introduce each other.
I'm very pleased this afternoon to introduce Lindsay, a fourth-year nursing student. As a nurse, Lindsay will be a huge patient advocate, working holistically with patients and their families, both at bedside and in an outpatient setting. As a nurse, Lindsay will perform frequent patient evaluations, including monitoring and tracking vital signs, performing procedures such as IV placement, phlebotomy, and administering medications. Because Lindsay will be working so closely with patients, she will most likely be the first to notice problems or concerns with the patient and will report to the physician. She will also be involved in educating patients regarding disease prevention and proper hygiene if necessary. In addition to working closely with patients, Lindsay will also be working very closely to other healthcare personnel, such as physicians, pharmacists, PTs, OTs, PAs, NPs, and social workers.
Thank you, Sima. Hello, everyone. This is Colleen Wild, and she is a neuroscience major here at UNE. She was asked to participate in this project as the voice of a psychologist, as her major has rewarded her with much knowledge in mental and behavioral health. She represented the profession of psychology, by studying the mental status and behaviors of our client. This included an assessment of mental illness, thought process, values, and beliefs. She also focused on the unique behaviors of our client and presented differential diagnoses to the team for discussion. If she were a licensed psychologist working with the presented client, she would be responsible for diagnosing mental problems using the Diagnostic and Statistical Manual of Mental Disorders, or the DSM, and providing treatment with the goal of improving the client's quality of life.
Sima is a third-year student in the Doctor of Pharmacy program here at UNE. From the very beginning, she was very active in cross-checking medications and dosage levels, looking for optimal treatment efficacy at every turn. Having a pharmacist on our team is an incredible advantage. Not only does it ensure a patient's medications are being managed properly, but it also benefits us all as healthcare providers to have a better understanding of safe drug dosages and interactions. A pharmacist is the real go-to person when a patient or even another healthcare provider needs or wants to know more about a drug treatment. And I believe I speak for the entire team when I say that Sima was an integral part of making this team such a success. So now Janine will be introducing Tim.
It's my great honor to introduce the only guy on our team. Tim Givens, a second-year physical therapy student. Tim represents a profession that diagnoses and treats individuals who live with health conditions and other health-related issues which limit their ability to move or perform activities of daily life. PTs possess expertise in a variety of techniques and modalities in order to decrease pain, prevent further disability, and restore function. Physical therapists also collaborate with other healthcare professionals in order to help individuals prevent the loss of mobility and help support independence in both the home and the community. By addressing the physical aspects of rehabilitation and care, PTs also support an individual's quality of life.
And now I will introduce Janine. Janine is a fifth-year occupational therapy student here at UNE. Occupational therapists help to give people back to the things they want to do. The term occupation in occupational therapy stands for any activity that surrounds self-care, activities of daily living, functional mobility, work, communication, and social participation. OTs address physical, cognitive, and social aspects of people's lives through holistic and collaborative approaches. Ultimately, OTs help clients become as independent as possible with their daily activities. Now, Lindsay will present the concept of IPEC.
Thank you, Tim. The following information on IPEC was gathered from a report of an expert panel and sponsored by the Interprofessional Education Collaborative, also supported by the associations displayed here. I quote the report when describing a vision of interprofessional collaborative practice as key to the safe, high-quality, accessible, patient-centered care desired by all. Achieving that vision for the future requires the continuous development of interprofessional competencies by health profession students as part of the learning process, so that they enter the workforce ready to practice effective teamwork and team-based care, end quote. This vision is much like our goal as a UNE student interprofessional team. The positive outcomes gained from this experience were the result of a demand for interprofessionality, teamwork, and team-based care. These concepts of interprofessionality are borrowed from Damore and O'Dandison's definition, which accounts for a share of their work with Health Canada. Over the last months, we have worked together as a group and were able to practice thus firsthand. Among meetings with faculty mentors were numerous student gatherings where we discussed potential client needs and related collaborative treatments. We recognized a variety of needs and collectively addressed them using the knowledge of each profession. During the process, we went from a group of individuals, or students of health professions, to become a unified team who understands how to achieve better patient outcomes through interprofessional teamwork. Accomplishing this required understanding the concepts embedded within the competencies, and those will be discussed in just a few moments. This concept of teamwork delves beyond the care provided to the patient to describe a system which functions with varying personalities, values, strengths, weaknesses, and even schedules. Planning multiple meetings with faculty, the client, and among ourselves often proved to be a challenge regularly faced by practicing healthcare teams. You may say that we have a collective identity as a UNE student interprofessional team. We were challenged by the university and by our individual programs to work collaboratively on what is now today's case conference. We were encouraged to use the presented complex case as a means of better understanding the significance and intricacy of team-based care. One might ask why it is so important to understand such. Interprofessional collaboration in education is a rising trend and would, as I quote, prepare all health profession students for deliberatively working together with the common goal of building a safer and better patient-centered and community population-oriented U.S. healthcare system, end quote. We have discovered through our research and experience that weaving the interprofessional theme into health professions, colleges, and universities is essential for a change in practice. Supporters of IPEC believe that providing collaborative care in the form of healthcare teams and including the patient, family, or community as a member of that team will improve patient outcomes. This topic is also timely as it relates to the Patient Protection and Affordable Care Act of 2010. This act has inspired new approaches to improve outcomes in primary care, including the medical home concept. Without going into detail on that idea, it can be said that interprofessional teamwork and team-based care are critical components of the new primary care approaches. I would like to conclude this portion of the presentation with a brief discussion of UNE's relation to the interprofessional collaboration movement. The initiative began in 1999 and since May 2010 has been recognized as the Interprofessional Education Collaborative, or IPEC. UNE's website states that faculty and staff of the college have demonstrated a consistent commitment to collaboration in research and scholarship, curriculum development, and critical and community service. This group, now represented by faculty, staff, and students, is responsible for the many interprofessional collaborations which take place among both campuses. As a product of UNE's Interprofessional Collaborative, our group now recognizes and appreciates the value of interprofessional education. I'm going to hand the mic over to Tim, who will now be speaking about the core competencies.
All right, I will be speaking about the 4 core competencies that every team, interprofessional team, should be going by. First competency is interprofessional ethics. There is no one professional more valued or less valued on an interprofessional team. Doctor of osteopathic medicine is just as important as a PA, just as important as a nurse. We should value their expertise when talking to each other in the group. And we should also respect the patient's privacy when dealing with them. The second competency is interprofessional roles and responsibilities. This second competency, this is why we decided to introduce ourselves the way we did. We wanted to show how we now know how to present our roles to each other and how each other's professions know the other person's roles as well. This is very important in this competency. We also need to recognize our limitations. So that when working in a team, if we aren't able to do something, we can utilize the resources in the team and find the person who is an expert in that and use them as a resource. Next competency is interprofessional communication. This is competency number 3. Communication between team members should be clear, concise, and using terminology that is not discipline specific. So everybody should be able to understand when we're communicating within meetings and in documentation what the other person is talking about. Team members should also be open to ideas and opinions of other professionals on the team. This provides the team with different expertise that will be able to pick up on different issues of the patient, helping to close the gaps in care and lead to a better outcome for the patient. The final and last competency is teams and teamwork. Interprofessional teams must develop familiarity and skills working in teams to effectively manage a patient. Developing these skills will lead to a more interprofessional approach to patient-centered problem solving, integrating knowledge from different professions into the problem-solving process. Now I will introduce Karis, who will present the patient.
So from this point out in the presentation, you'll hear both patient and client used interchangeably. This is just a reflection upon the profession that's speaking at the time. So our patient, who brought us all here as a team, is a 62-year-old Caucasian male. As you can see, he has an extensive past medical history. As can be seen, he has most notably peripheral vascular disease, chronic kidney disease, occlusion and stenosis of both carotid arteries. The left underwent an endarterectomy after a CVA, while the right is currently being assessed to determine future steps. The patient also has diabetes mellitus type 2, peripheral neuropathy, hypertension, and an unspecified seizure disorder. It is important to note that this patient is 62, and medical diagnoses are not dated. This is because these diagnoses were present upon entrance into the VA system. Therefore, this patient could have had these diseases present in his 50s, if not 40s. Many of these diseases are characteristic of a geriatric population, so putting these upon a patient in his 40s becomes much more complicated. With an extensive past medical history comes an extensive list of medications. While I'm not going to read all these medications and doses to you, the VA does utilize its pharmacists to catch drug and drug interactions, as well as to perform patient education. Our patient utilized this resource frequently, resulting in him being well-versed in many of his medications, their purpose and their dosages, had education regarding their purpose and their dosages as well, an all too rare occurrence among most patient populations. So while I'm not going to read the slide of medications to you, our patient was very able to. The next few slides will show components of a comprehensive electronic medical record. The team noted a correlation between charting information and information gained from the separate visits with the patient, yet another phenomenon that is far too uncommon in the medical field. A large part of this consistent information is due to the open policy of the EMR system within the VA. Any provider within the VA that is directly involved in patient care, and regardless of the department, can assess medical records for that patient. As Dr. Bottomley noted, we worked strictly with TOGAS in the Portland VA clinic. They have about every specialty and department available, including an ER. The family history was collected from both the chart as well as the patient, but it should be drawn to the attention that the scarce family history marks an interesting aspect of this case. Our patient was exposed to Agent Orange. The lack of family history speaks to the severity of exposure and the sequelae that can result. Unfortunately, much of the pathophysiology behind Agent Orange is still poorly understood. You may note that the brother of the patient has an extensive history as well, but again, you'll see that he also had Agent Orange exposure and is more progressed in his diseases. Lesson 2, know your patient, for they are the driving force of your team. With this lesson in mind, the team found it pertinent to collect a comprehensive social history. Without understanding the patient's life at home, it is only a guess to whether he will remain an active participant in his own health. In order to do this, the team must understand their patient. Therefore, the team put an emphasis on collecting a detailed social history. Our patient identified as a Special Forces Vietnam veteran. His charismatic nature and optimistic views, even when faced with a debilitating disease diagnosis, was admirable and earned him a recommendation from his PCP to his participation in this case conference. Currently, the patient is extremely independent for his ADLs and IADLs, but as Janine from OT will discuss later in detail, preventative measures have been taken by utilizing the benefits that the VA system offers. This includes extensive modification to the patient's home, as well as obtaining a wheelchair, which a patient states he does not use because he wants to maintain mobility as long as possible. Again, a marker of a determined patient wanting to be involved in their care. Fall risk is substantial for this patient due to intermittent claudication, peripheral neuropathy, and his CVA history. Kylie and myself had the opportunity to conduct a neurological exam on this patient in which multiple abnormals were found, including hyperreflexia, decreased sensation of both lower extremities, notable left-sided weakness to hand strength, and loss of coordination to rapid movements. Therefore, not only does this patient require thorough examinations and treatments through his PCP and specialties, but there is obvious need for the expertise of both PT and OT to ensure the safety of the patient at home. I had the opportunity to ask the patient's PCP how he let such a complex case walk out the door. The physician replied, "The VA system is not for those who wish to leave work at work, but the accessibility of multiple providers and specialties and therapies is often the only reason he can put his mind at ease with some of his patients." Hopefully this portion of the presentation served as a brief summary to a complicated case that the team had the privilege of working with. However, the goal of the team was not to strictly offer a medical model case presentation, but rather utilize the different professions to best understand the patient. My colleagues will now discuss, through the eyes of their profession, interesting aspects of the case.
So today I'll be talking about Agent Orange and what it is. So Agent Orange is one of 15 herbicides that was sprayed in Vietnam. A total of 10 to 12 million gallons was sprayed between 1961 to 1971. Agent Orange is a combination of 50% 2,4-D and 50% 2,4,5-T. The chemical that caused the medical problems is 2,3,7,8 tetrachlorodibenzopdioxin, also known as TCDD or dioxin, which is part of 2,4,5-T. Agent Orange is colorless. However, it received its name from the orange band painted on the drums that it was stored in. Vietnam is 127,247 square miles. It's the second largest country in Southeast Asia. An estimated 4.2 million acres was sprayed containing 2,4,5-T, which also contained dioxin. According to the Vietnamese government, about 12,000 square miles was sprayed once, and over 10,000 square miles was sprayed twice. 5% of the forest was destroyed and 50% was damaged. The purpose of Agent Orange was to defoliate the hiding places used by Viet Cong and to destroy the crops that was being used to live on. So this is a map of Vietnam. Everything in red is where Agent Orange was sprayed in the country. And you can see the extent of exposure that civilians must have had. Some facts about TCDD. There are 75 polychlorinated dibenzopdioxins, and TCDD is the most toxic. It's extremely stable, slowly metabolized, not rapidly eliminated, and extremely persistent. It's strongly lipophilic, and the half-life in the human body is 7 to 12 years. And this means that 50% of the drug is eliminated from the body in approximately 12 years, and it would take 5 times this to eliminate all of the dioxin from the body. It particularly accumulates in the liver and adipose tissues, and there's a high potential for accumulation following repeated exposure. Toxicity of TCDD. There's a positive correlation between increased serum and adipose levels of TCDD and increased risk of chloracne, hyperpigmentation, and abnormal hair distribution. There's been increased mortality from non-malignant liver disease, increased risk of developing diabetes, thyroid dysfunction, impaired immune function, and increased mortality from cardiovascular disease and mild neuropathies. It is also important to note that the exact mechanism of how dioxin causes these disorders is unknown. Back when the US government sprayed TCDD, they believed that Agent Orange would only contaminate the environment where it has low bioavailability, and absorption through the skin was unlikely. 90% of the dioxin is destroyed through photodegradation, therefore it would have not reached the troops. However, after seeing the correlation between the diseases it caused, Agent Orange Act of 1991 was passed. This law enacted certain ailments presumptive due to Agent Orange dioxin exposure and enable Vietnam veterans to receive treatment and compensation for their health conditions. This is just a brief list of disease and conditions that are presumed for which Vietnam veterans receive compensation. So just a few of them here are chloracne, non-Hodgkin's lymphoma, soft tissue sarcoma, head and neck cancer, and spinal bifida. This is a picture of someone who was exposed to Agent Orange and suffered from advanced head and neck cancer. And you can see the extent of toxicity that is caused by Agent Orange. This is a brief case report that I found of a patient who was a Vietnam veteran and was exposed to Agent Orange as well. I wanted to point out some similar disease states between this veteran and our patient that we followed. Both patients suffered from DVT, TIA, diabetes, type 2, and neuropathy. Some of the other diseases that this patient suffered from are nocardial infections, carpal tunnel and arthritis, and blurry vision. and first degree AV block. Next, Colleen will talk about psychological aspects.
At the beginning of our IPEC experience, we were told that many veterans tend to not want to share their combat experiences because they feel that these experiences have the potential to traumatize others. However, we were also told that there are some veterans that will share the tragedies with you as a way to test you and see how you behave and react to these, and if you are someone that they can share these experiences with. Many also have been reported to carry aversions to vulnerable situations or to individuals who may lack composure and strength. So you can imagine the level of control that's required of a healthcare provider working in the VA in order to build trust between the veteran and his or her healthcare provider. Another important topic to touch upon, being in a room full of current and future healthcare providers, is post-traumatic stress disorder. PTSD, to give an idea of PTSD in the military, it had many names such as exhaustion, shell shock, combat or battle fatigue. And in late 1970s, it was given the title of post-Vietnam syndrome surface, but it wasn't even until 1980 that it was formally recognized as a disorder and added to the DSM-3 as post-traumatic stress disorder. However, many World War II and Vietnam veterans resisted this diagnosis because it was seen as a disability or weakness to be labeled as PTSD at the time, and some would still say today that they would feel the same way, which brings me to our client because he himself believes that, in his own words, described PTSD as a cop-out or for weaker-minded individuals. So I'm going to share a few of our clients' behaviors that our team encountered that were beneficial to our client as an individual, but behaviors that can also be challenging for healthcare providers. So to begin with our client, he was charismatic, generous, open, and willing to share his home with us. After our first client meeting, it was very difficult to separate, on one hand, the personal liking we had for having such a pleasant patient to work with, and then on the other hand, staying focused on the professional roles we were there to fill. So, so after some discussion following our initial client meeting, we began to see that our client projected certain attention-seeking and histrionic behaviors. He would tell exaggerated stories that would make him appear strong or clever, and using exaggeration, he's able to draw in an audience that sympathizes or admires him. For the client, these behaviors allow him to attain the personal and medical attention that he needs, but in a way that does not require him to ask for the help or care. In this way, these behavioral tendencies are very beneficial to our client's mental state, since they protect him from feeling disregarded or vulnerable. There were also many times that he would passively seek praise from our team by drawing attention to the positive attitude he's maintained through all his mental and through all his physical ailments, which is very commendable. However, he used this as a way to draw our focus away from the task at hand. We also began noticing gaps of information that our client chose, or gaps of information he left out, and questions he was able to work around answering by redirecting the attention to his positive attitude instead of answering our questions with some depth. But being able to recognize these behaviors was, made us more equipped for acquiring the information we needed from our client, and we also learned to be more aware of the topics our client chose to avoid and what he chose to share with us, and really open our mind to why he was sharing certain things and why he was avoiding certain things. It was a challenge at times because he was very strong-minded. He did test us at moments by sharing graphic memories of war, less for his own need to share, but more to see how we handled that kind of graphic information. He was able to share disturbing images without hesitation, in a detached manner while appearing unmoved by the details. He shared these memories as though they were something he witnessed at a distance, but not as something he was emotionally connected to. He also told us how he mostly keeps in touch with in his words, his stronger-minded siblings, some of whom were also in the military, while describing the siblings that he doesn't communicate with as much as weaker-minded. Although his tendency to be hypercritical of more sensitive individuals may add complexity to clinical work, his routine of blocking vulnerability in sensitive individuals from his daily living may make it easier for him to remain desensitized to some of the traumas he's lived through. Our client is also religious, and this may account for some of his positivity through all of his medical concerns. It may also be why he has found a way to cope with any acts of violence that he took part in or experienced during his years in the military. Religion and belief in a higher power can create what is called an external locus of control for the individual who holds those religious beliefs. This meaning that the individual's outlook on the order and occurrences of events in his or her life are not in his or her control, but in the control of a higher power. This allows the individual to let go of responsibilities and burdens of the ailments and traumas they experience. His religious beliefs may have given him the ability to cope with what he has experienced, and his ability to cope may explain why he devalues post-traumatic stress disorder as a real illness. It is clear that there are many complexities to the mind of a combat veteran, and to be able to work with them toward a higher quality of life is a very rewarding experience. It's the least we can do after what they've given to our country. But now Kylie's going to share some words regarding the experience of working in the Veterans Administration.
All right. Oop. Crap. All right. So, just to talk a little bit about the VA system, it is one of the largest healthcare systems within the U.S. It's the second largest agency of the federal government after the Department of Defense, and benefits for veterans in the U.S. dates back to 1636, to when the Pilgrims were at war with the Pequot Indians. And benefits available to vet include access to the healthcare system, access to reduced price medications, and access to home modification benefits. And all of those benefits I just listed are ones that our patient has received. Also, since we're all, for the most part, going to be healthcare providers, we thought it was interesting and relevant to talk about some of the benefits for actually working within the Veterans Administration's healthcare system. So the first one being the patient population. As the VA likes to say, they're serving those who served, which is obviously great to be able to have a certain amount of respect for all of your patients, regardless of where they come from, and be on a certain playing field with them. On the other hand, that can produce some complexities and some interesting situations, as Colleen noted. Other benefits include federal benefits, having more flexibility with time off. There are some loan repayment programs. Another obvious benefit is you don't have to worry about the patient's insurance when it comes to ordering tests or different procedures, just because they are all in the same insurance. Research opportunities, there's a lot of the different medical discoveries that have been made in the recent history have been made through the VA system and through their research. And one thing that I found particularly cool is that you only need an active license in one state in order to be able to move, as long as you're staying within the VA system. So if you get really sick of the winter weather up here and you want to move to California, you already have the license, so yay. We also had the opportunity to talk to the patient's primary care provider and sit down and talk with him. And we were able to talk to him about working as a healthcare team, both within the VA and when he has to work with people outside the VA. So within the VA, it's obviously a little bit easier, and that's what they'll usually do, is stay within the VA for most referrals and tests and et cetera. One benefit is that they do have the same EMR system all throughout the VA, so anyone can, any person providing care for that patient can access all of the other notes, lab results, imaging, et cetera, that patient has received, going back to since they started the EMR system in the VA. Also, it's easier to contact other healthcare providers since they're all within the same system. If they do have to go outside the VA, sometimes it's necessary for more practical reasons, just because, for example, with colonoscopies, the patient's primary care provider was saying how it's a lot easier because of a long wait list within the VA to just refer some of his patients to go get their VA done at their colonoscopy done at Maine Med. So sometimes they will refer out for certain procedures. Also, and this is really interesting, some of the veterans within the VA have 2 primary care providers. The reason for this goes back to the fact that before they started introducing reduced price medications, some veterans already had their own insurance, et cetera. And then once the VA offered more reduced price meds, they jumped into the VA system but kept their original primary care provider. Or also, visits to the emergency room weren't always covered by the VA, whereas now they are. So in the long run, there are some veterans that still have 2 primary care providers. So obviously that can produce some interesting situations with coordinating care, but they're trying to move away from that, but it's a reality. And then also it can be troublesome obtaining progress notes or getting results of consults if they've gone outside the VA system. And so now I believe Janine is going to talk about some home modifications.
Thank you, Kylie. Okay, so I think I can speak for the rest of the team when I say I felt incredibly fortunate that the client allowed us not only into his home, but into his life as well. And I feel even more fortunate because home modifications and environmental modifications is a large and personal interest of mine. Now, home or environmental modifications may sound boring, but actually it plays a significant role in everybody's life. A person's home environment is a place where you always feel comfortable. You don't have to think about climbing into bed, reaching over to turn off the light, turning on the stove, etc. And as we all know, there's no place like home. Had to throw that in there. So, in many theoretical models within occupational therapy practice, a person's occupational identity, or that sense of self that is shaped by purposeful or meaningful activities of everyday life, is shaped by various variables and factors such as a person's motivation, spirituality, their physical and cognitive function, their personal experiences, the actual occupations they perform, such as self-care, leisure, work, how they perform those occupations in routines or patterns, and of course, the environment in which they do these occupations. So without an accessible environment, particularly in one's home, a person's occupational identity becomes imbalanced, thus negatively affecting quality of life. I remember a couple years ago, a professor once told me regarding accessibility, the issue is not an individual's inability to adapt to their environment, but the environment's inability to adapt to the individual. In this particular instance, although our client had a very positive outlook on life and didn't really immediately state any problems he was having, he did state that his biggest problem was functional mobility throughout his home due to the pain in his legs as caused by his peripheral vascular disease. This especially affected his ability to go upstairs and walk certain distances about his home. So, in order to face these challenges, his house was completely modified by the VA. So compared to home modifications outside the VA healthcare system, most of the time, numerous kinds of fundings are sought, such as from insurance, grants. Sometimes you have to go outside and look for a foundation. So, the VA has 3 main grants to assist veterans with necessary home modifications, interestingly for both service-connected and non-service-connected veterans. So like I said, there's 3 different kinds: Specially Adapted Housing Grant, the Special Home Adaptation Grant, and the Home Improvements and Structural Alterations Grant. And there are certain criteria veterans need to have in order to apply for one or more of these grants. The SAH is designed to help provide a barrier-free living environment. It's available to veterans who will be entitled to disability compensation for permanent or total disability. Any disability that really precludes locomotion that would require modifications for crutches, wheelchairs, canes, etc. And there is limits to how much each grant has. This particular one is a little over $63,000. The Special Home Adaptation Grant is really for modifying existing homes, and that again is limited to a little over $12,000. And there are specific things or criteria you need to have for that one as well. And the home improvements and structural alterations grant are for both service and non-service connected veterans. And you also need to have medical determination for this particular grant. So to modify his home needs, the client had said he received over $60,000 from a grant. He didn't specify which grant it was, but it's safe to assume that it was this specially adapted housing grant due to the amount of money given. He said that contractors and other professionals came into his home and evaluated his environmental needs, and the VA oversaw everything they did. So a little bit about the client's home modifications. There's an addition of ramps for the possibility of wheelchair use. Like it was said before, he's ambulatory right now, but the VA did give him a powered wheelchair just in case he gets to that point, if he gets to that point one day. They added the addition of hardwood floors, removal of any thresholds. All his necessities are on the same level: his bedroom, the bathroom, the kitchen, the laundry. Accessible height of countertops, they were lowered. The closet was lowered. Windows, bed, toilet. Door widths were increased. Stair width was increased. And the client also insists on getting a stair lift for his home, in which he'll have to go back and ask for that, or possibly apply for a different grant. So again, the client graciously gave us the permission to take pictures of his home. He wishes to say that his fiance is moving in, so if you see any messes, he's sorry for that. We also asked if the client had any input regarding his home modifications, and he said no, but nonetheless, he was very satisfied from what the VA provided. So just to show you some actual examples, the following slides are pictures of his home. So just an example, they increased the width of the stairway, the addition of the hardwood floors there. All of his doorknobs are now lever-based, so that's an easier access. There's a small ramp added. Obviously, the hallway was widened. Another example of a doorway being widened. The bathroom, they added a walk-in shower with the addition of grab bars and a detachable shower head. He does have a shower bench as well, but it's not shown in the picture. They raised the toilet, they added grab bars, no problems there. They lowered the countertops, and they even added a nice heater below the counter so his feet can stay nice and warm. Nice. Okay. They also gave him some front load, a washer and dryer, again on the same level. And they even added a stove and made it higher so he has easier accessibility when he's cooking food. And this is his bedroom. They lowered his bed, and it's hard to see, but they also lowered his windows as well. And the cat obviously doesn't mind. And I'm going to throw it back to Kylie.
All right, so what can we all take away from this, and especially here at UNE? So in regards to the VA system, looking at it as a model for a potential UNE student healthcare clinic, one big thing that we all appreciate and we think that we could use at a UNE student clinic would be the accessibility of information to all, because there was this great EMR system. I don't know if we could get that at UNE, but that'd be awesome. But either way, even if we can't, just having the charts centrally located or located someplace where all the different disciplines could access them. Another great program that the VA has that we thought would be fantastic is they have a program called My Health eVet, which is it allows the patients to access their own medical records at home, so that way they can really play a part in their own healthcare and know what's going on with themselves, which is great and would be a great thing for a UNE student health clinic, or even just for in our own future practices. It's something just to keep in mind. Structurally, one great thing that we were able to benefit from when we met with the patient's primary care provider was just conference rooms. It is a great place for people to be able to, for an interprofessional team, to be able to meet and discuss a patient. And they were also used for patient wellness classes. Our patient's primary care provider put on weekly classes, and each Friday morning he would do it on a different topic. We think that if there would be a UNE student health clinic, a great idea would possibly be for each healthcare discipline to put on a lecture for patients on a different topic once a week. So OT or PT could do biomechanics, nursing, PA, DO could all do either nutrition or diabetes control, et cetera. I'm sure we could come up with lots of more ideas of how our professions could put on different classes for patients. And then how could what we learned working as an interprofessional group be a model for a UNE student health clinic? One thing that we thought was great was because we are all working together early in our careers, it's before any biases can form. So it's, I don't have any preset ideas of what I think a nurse does or what I think they can't do, et cetera. So it would just be something to keep in mind with a UNE student health clinic is to make sure that everyone's at about the same education level and about the same place in their careers so that everyone's on the same level. Another thing that is that, and as you've seen us do it, and it relates back to one of the competencies of roles and responsibilities, is establishing and understanding the overlap and differences between each of the own disciplines. We felt that was key for us working as an interprofessional team. You can see that in our introductions, we all introduced each other, and the way that started was at our first student meeting, we just went around the room, kind of gave a quick description of each of our disciplines and what we could contribute, what we knew how to do, things we hadn't learned yet, just so we were all sort of on the same page. And then at that next meeting, we just drew names out of a hat and started describing each other's disciplines so that we all kind of had an understanding of what the different professions could contribute and where they also all overlapped and where they shone. Another really important thing is communication. So for us, that was just by email. We met regularly once a week, and sometimes more than that. That would just be very key for any other student health clinic with different professions, is just making sure that everyone was able to communicate with each other, and on the same level with language that we can all understand. And lastly, just the respect for the fact that we are all in grueling programs. For us, that translated as that if one of us couldn't make it to a patient meeting or to an appointment, et cetera, we all understand the fact that if someone has a test this week, their program is important too, their program is also hard, and just respecting that fact, and knowing that we're all kind of in the same shoes. So that's kind of what we've taken away. I'll just say for everyone, thank you to my teammates for working together because it was a great experience. Thanks to our faculty, and thanks for all of you guys for listening. And I think now we're going to turn it over to some good old-fashioned Q&A. That's just special thanks.
Thank you very much. We have time for questions. I should have initially shouted out to our colleagues on the other campus in Biddeford. Dr. Dave Mokler from the College of Osteopathic Medicine is down there with a group of students, and they are emailing questions up to us that we can ask of our interprofessional student team. So anybody who asks a question needs to have a microphone in front of them so that the folks down on the Biddeford campus can hear it. Who would like to start? Don't be shy. Anybody? Yes.
I just wanted to ask the whole team, it sounds like you've spent a lot of time. I've only been involved in some of that. How do you think the lessons you've learned will translate to real practice where, Kylie, you'll be seeing 15 to 20 patients a day? How will it work, this interprofessional collaboration in the real world?
All right, so I'll start off with that. I actually really am interested in anesthesia, so this is perfect because within anesthesia and within the OR, there's a really big team environment anyways, both with anesthesiologists, nurse anesthetists, the surgeon, OR techs, et cetera. So I really hope that this will translate because it is something that, a skill that all healthcare providers are gonna need. And I think that however health insurance changes in the future, all of the healthcare professions are going to need to be able to work within a team environment just to be able to see the amount of people we're going to need to see and to get as much as we're going to need to get done. So, I just think communication and respect is really what it comes down to, but I think it's something that everyone's going to benefit from, so. Which way do we want to go?
One thing I really did appreciate about this experience is that since we are at this point in our education careers, that there really is this lack of prejudice amongst us, because I know older generations there's a lot of, I have more power, or there might be like, oh, I'm the doctor and that's the psychologist, and like, this is your role and these are your boundaries. And it was just really nice because at this level, getting to see and really understand each other's roles, you kind of just see that without each other, like, you can't be effective. Like, they fill in the gaps and you need that. And they, with that, I just don't know how it's worked in the past, looking at it this way. So it definitely was great to really have a full understanding and have that mutual respect for, because what we're all here for is to just enhance the lives of our patients and clients.
I think I can also touch on how it would translate into practice. I think realistically, as you said, you see multiple patients or clients a day. And so on a daily basis, working in a team, that may be more difficult. However, I believe it is possible, whether it's weekly, bi-weekly, or monthly meetings, collaborating with your coworkers in the other professions to discuss strengths and weaknesses on patient outcomes, and maybe how you can improve from there.
One of the major things I got out of this was that communication is key, and that it can be really hard. We had to schedule meetings late, and sometimes communicating with different people. We were trying to get records and trying to communicate with the patient was pretty difficult. So I got out that it's hard to communicate sometimes, but you just got to work through it, and as a team you'll get through it, and it's pretty key.
I can see this translate into something that is actually already present at Maine Medical Center. It's called Hospital to Home, where nurses, well, not really nurses, sorry, where social workers, pharmacists, and physicians actually sit down together and talk about medications and what basically the patient has to do to not actually go back to hospital, and also talk about why he ended up in the hospital and how that can be prevented. In addition, a lot of times, in addition to taking prescription medications, patients also end up taking herbal medications and not realizing that it actually can interact with their current medications. So having a pharmacist there and having us actually look up that drug interaction and stopping the patient from taking the herbal medication is also key.
I think the biggest thing I learned was just learning about everyone's different professions. I think I learned, ask questions, and I really learned how to look through the eyes of, again, different professions other than my own, at looking at different perspectives all the time.
Just being of a younger generation in healthcare, what I hope to take away from this and what the PCP really pushed is that we have been shown a model that is very effective and works, and there's no reason that we can't promote that in our future clinic outside the VA. The EMR, as we discussed, is extensive and amazing, and it works. So take what works, know what works, and push for it in your future care.
We have a comment and a question from Biddeford. Excellent job to the team. What can your individual programs do to increase interprofessional education so all your student colleagues can have the experience that you've had?
So we're the DO program is the only healthcare program that isn't on the Portland campus. So we're left out a lot. So I know that the first years were able to come up here once, but this is actually something I've brought up to the deans too since I got involved with this program. I honestly think that my colleagues should be jealous just because I do really think that it's been like a great experience, and I think that it will translate, and I think that I've learned a lot from it. And I think going out into the hospital next year and just already having a really good understanding of what all of these different professions have gone through to get where they are, and how they can hopefully help me, will really help. But so how we can add to that? I know that the first years came up here at one point, I think with the PA students, for an interprofessional thing. I think that would be great. I would love to see that in every class. I would love to see that more than once a year. I would love to see some sort of a mandatory thing like this for most of the professional students, so it's not just like one student from each program, but perhaps a bunch of little groups like this. But so anyway, so there's a lot that can be done, and I think also if there is a student health clinic, just making sure that all the professions are involved with it. That's how I got involved with this program, because I think the student clinic is such a great idea, and I think just the more contact that we can have with each other, the better. So yeah, who wants to jump in?
Just to add to that, I think one thing I've often wished for is an interprofessional simulation program where we could do, nursing does SimLab where we go in and are presented with a case. And to do that interprofessionally would be a challenge, but I think it would be a way to touch each of the professions and every student. And also something that I kind of did for the first time this semester was nursing students went in and taught OT students, I believe, how to do blood pressures. So simple things like that maybe OT can come back in and teach us more about mobility or PT. We could kind of teach each other in that aspect.
In addition to what Kylie and Colleen or Lindsay mentioned, I think it would be really interesting to possibly have an elective where certain slots are open for DO, psych, nursing, PT, OT, PA, and pharmacy, and we could all just maybe come together and talk about cases.
Despite the fact that the PA program is really only on campus for a year, so it makes this whole IPEC thing really difficult, I think, for our program. I think we've been doing a great job. We've been working with OT and PT in our interprofessional geriatric program, which has been great, and I think my colleagues in the PA program would attest to that. But continuing to do that and just to maybe promote atmospheres like this more. It was a lot of work. Our program's rough, but you can make it work with a team, especially an understanding team, to do these meetings. And I'm not sure if it would be possible to just branch this kind of thing out more, but just small groups like this work. So.
That's a perfect segue. I'd just like to follow up with a couple of things. First of all, I want to thank everyone who participated in this experience this year. I think it's extraordinary. You're a wonderful example of a team for us to all hear from today. So thank you. It's also particularly gratifying to hear your suggestions because I think it's just music to our hearts. All of us who have been focusing on IPE for a while, we love every suggestion. We would like for every student in all of our health professions and related programs to have an opportunity to work in a similar situation together. So that's our goal, is 100% participation. We're working towards that. The other thing I want to say is we continue to come up with innovative offerings, and one of the things that I wanted to just give a shout out to is John Langevin from our Student Services and Colonel Andrew Gibson, who are going to be this fall offering a course, an interprofessional course on working with veterans. It's going to be titled Therapy for Those with Military Service and Their Families. It'll be offered for both graduate and undergraduate students, so we hope a lot of you will sign up. Thanks, George.
More comments, questions? Meet you halfway.
I noticed that spina bifida was on the list of side effects, and I was curious as to what the manifestation is with that, like how that shows up as a result of exposure.
As a result of
So this wasn't the case with our patient manifesting spina bifida, but it's simply exposure. A parent, a woman who was pregnant at the time, has exposure. They're even with folate supplementation and everything, they're just still very, very high risk for that to manifest in the neonate.
Another question, comment? Yes.
No, he just answered.
First, I just want to say you guys did a really great job with the presentation today. I really enjoyed it. We didn't really get to hear from PT much about what they would have done. Sorry to put you on the spot. And I was sort of wondering, it seemed like a lot of the adaptations in his house, and maybe this is for OT as well, seemed, you know, and I know you said his attitude was very, that he didn't want to use things that he didn't need at that time, but for other people that don't have that attitude, are those kinds of adaptations sort of setting them up to further decline? You know, I'm just not really sure how that works.
So, as a physical therapist, as we said, he's at high risk for falls. So I would be working pretty extensively on the fall risk prevention, such as working on his balance, also working on, because he has neuropathy, working on compensatory strategies he's reminded of to like look at the ground or look at something he's walking over because he can't exactly feel on with his feet. Also, because he has peripheral vascular disease, he is only able to walk around, he said around 180 feet, so he can only walk up and down his driveway twice. So I'd be worried about his cardiovascular fitness, and we'd be trying to put him on a program that would work on that. So that's what I would mainly be involved with.
You bring up a great point, but you do have to apply for those grants, so it's not like the VA is just going to give you adaptations. You have to want them yourself. He did want them, so he did apply for the grants. And I guess I kind of saw it as more of a preventative kind of and maintaining function in my perspective, but I can definitely see your perspective, though.
Anybody, any more questions?
So multiple times y'all mentioned that he had an overall really positive disposition. But looking at his list of his past medical history and the fact that it started at a young age, what was your overall perspective, I guess, of his perspective on the reality of all of his medical conditions, especially at such a young age, and what that looked like for his longevity, I guess?
So that was actually something that we brought up with his primary care provider when we sat down and talked to him. We're just kind of asking about, is he always that positive? Was he always that positive? Is that a good thing? And one of the things that he said was, the primary care provider was, yeah, like that's just how he is. That's part of why he recommended him for this program. And personally, like upon first seeing that, because we saw his disease list first and like his med list first, and then we met him and we were all just blown away. And that's something Colleen kind of said too, but we were all just like, oh my God, he's awesome. And I want this patient all times. Just because he is really positive, and it's really, you know, somewhat inspiring to see a patient with so many diseases just to keep such an outlook. Obviously, as Colleen went into it, there's a little bit more to that. But to get to your question specifically, one thing the primary care provider did say is that to some extent it could be a negative, like he just sometimes wasn't so realistic. And like you would be like, oh, well, how's your diabetes? And he would be like, that's fantastic. And his blood sugar's like 240. So, you know, it was, sometimes he wasn't really negative about a lot, and sometimes that is another possible downside is not realizing that there's still room for improvement. So I think that answers the question. All right, cool. Anyone else want to add? Okay, all right, cool.
Where was social work involved, and why? How do you think that would have added to your case study?
So, social work was not involved, just based on student availability. I think we've all kind of said that we saw nursing's role in this as having a caseworker would be great. Yes, thank you.
Yes, as a nurse going into this, clearly it wasn't an inpatient setting, and he didn't really require any nursing home care or home care from a nurse. So I was kind of challenged as to what my role would be, and with the lack of a social worker in this group, we all kind of agreed that it would be best for him to have somewhat of a case manager. He had numerous appointments with multiple specialists. He had many medications. There was a whole laundry list of things that gaps could have been missing. And it was important that someone monitor to make sure that he's going to all those appointments and that he's taking all of his medications and that all of his needs are being met.
Anybody else? Yes.
You mentioned that you closely worked with his primary care, and I'm under the impression that his primary care also worked in an interprofessional environment. But I want to know from you guys, I think you had the unique opportunity as a group yourself to look at a new case like this. Did you pick up anything in his medical care or his prognosis or any diagnoses that may have been missed? Or did you guys see anything that you saw that could be an improvement in his case? I assume not everything is perfect in his records.
Well, one place I can start is that he didn't have a psych evaluation in his file. He said that from his special forces, his time in special forces, that when he retired from the military, they somehow locked those away and that they might not be available for us to look at. But I think that over the years, I would suspect that someone would have suggested that he that he should go get a psych eval, especially with all the ailments and like medical concerns he's gone through. And it just seems that he's chosen to not face that and go through with it because there was no evaluation in the file.
So we actually did catch something, and the PCP was very receptive towards it. And it was first drawn our attention by Dr. Oakes, pharmacy. The insulin pump did not have a basal rate to it, which insulin pumps are supposed to, but it wasn't reading as having a basal rate. So when Kylie and I and a couple others went to talk to the PCP, we mentioned, you know, what is this insulin pump that doesn't have a basal insulin rate being administered? I've never heard of that. And he goes, it's supposed to. So apparently the pump was broken. So that was pretty much one of the big things we found. And other than that, just the PCP was actually very receptive towards us talking to him and being like, wow, you've been in his house. What's going on in his house? And gave us a little bit more information on the social history he had. We kind of bounced back and forth. So a lot of the social history things, and he wasn't aware that the patient wasn't being compliant with his walking program anymore for intermittent claudication. And so just some different things like that, kind of bouncing ideas back and forth was kind of cool.
Yeah.
In a world where insurance companies dictate so much of medical management, are there any incentives through the insurance companies to use this approach, which might take a little more time to be productive in?
I think in the VA there is, and that's my own little plug because I want to work in the VA. I mean, I think that's that kind of fosters it a little bit more. I mean, I think that if you could reduce medical error, I think there's an argument that can be made for it. Like, are there any incentives for it now? Probably not. I certainly don't know enough about every single insurance policy to actually know. And I don't know that, do any of you guys know, if there are any actual incentives right now? Probably not. But I mean, if you can catch medical error and if you can prevent a disease from getting worse, I'm pretty sure you can make a really strong argument that the more hands you have on a person, the more covered they are. So you're gonna hopefully catch errors and prevent less of that. And if there are less errors, less lawsuit, less need for high prices in healthcare. So there's an argument for it.
I'd just like to add too that the major competency we touched on understanding each profession's roles and responsibilities, I think insurance companies would appreciate, because there'd be less referrals. I would assume we'd be able to kind of work with each other as opposed to always referring to somebody else.
Anybody else? Yes. Whoa. If anybody has a question in the peanut gallery, they can come down and ask.
Hi, I had a quick comment about incentives for insurance companies. I've worked in the VA for a couple years and been really lucky to see that, and also in Kaiser Permanente, which is what they call a capitated system. So the payer bears all the risk for medical care, including if something gets missed, like a high-priced hospitalization, if they miss, basal insulin, something as important as insulin. So sometimes it works well if you have a payer that bears all of the financial risk, and maybe less well if payers don't understand some of the benefits for things that aren't covered, like nutrition or wellness or physical activity, at least not yet.
Anybody else? Seeing no hands, I just want to say what a gift it's been for the faculty to work with such a curious and cooperative and collegial and communicative group of students. It has been a gift to us to spend the time that we've spent with them. And what I'm just sitting here thinking, if the future of healthcare is in the hands of students like these and students like you, I think we have great things to look ahead to. So thank you again so much for the privilege of working together. And thank you down in Biddeford for being there. Thanks, Dave. And thank you very much for being here today. Bye-bye.